Buenos días y bienvenidas, bienvenidos a la jornada de la Fundación Garcia Cugat de este año 2020, peculiar y extraño por la pandemia que nos está afectando y nos obliga a que la participación de ponentes y asistentes sea virtual. Dicho esto, vamos a empezar con un recuerdo especial por todas y todos que nos han dejado. Esta reunión también es por ellas y ellos. A pesar del intermedio forzado de la actividad, la Fundación ha proseguido su marcha y por ello envío un mensaje de optimismo a todas y a todos los que exploran y aportan nuevos conocimientos al potencial que tiene la biología para solucionar problemas de salud y aumentar la calidad de vida. El programa de este año contiene 3 sesiones diferenciadas. La primera se desarrollará en inglés y los conferenciantes que impartirán charlas serán, en primer lugar, el profesor Marc Güell, que ganó el Premio Nacional de Investigación al Talento Joven 2018. Es investigador experto en biología sintética, edición genética, terapia genética y el microbioma de la piel. Muchas gracias, Marc, por haber aceptado participar en este encuentro. En segundo lugar, el profesor Mitsuo Ochi, actual presidente de la Universidad de Hiroshima, que fue previamente catedrático de cirugía ortopédica y traumatología de toda la prefectura de Hiroshima y que tiene multitud de publicaciones y trabajos, nos dará su charla. Mitsuo, all our respect and thanks for giving a talk at the web meeting. Y en tercer lugar será el doctor Ramón Cugat, y de él solo diré que es presidente del patronato de la Fundación y cirujano ortopeda de la Mutualidad de Futbolistas. Así es como a él le gusta que lo presente. La segunda sesión ya será en español y versará sobre diferentes tratamientos biológicos de las lesiones de cartílago. Quiero dar las gracias al doctor Silverberg y muchas gracias a las doctorandos Alcaide, Torres y Peláez, que presentan parte de los trabajos con los que optan a la obtención del grado de doctor. Luego, entre la segunda y la tercera sesión, habrá una pausa para descansar y reponer energía. La tercera proseguirá en español y abarcará más aspectos biológicos y mecánicos. Agradecemos al doctor Garcia su charla sobre la reparación del manguito de los rotadores con un implante bioinductivo, al doctor Seijas por explicarnos otro tratamiento biológico de las lesiones condrales, al doctor Hernández Fernández por hablarnos de materiales bioreabsorbibles, al señor Querarón por explicarnos las utilidades de un sistema mecánico computadorizado que evalúa el grado de laxitud e inestabilidad de la rodilla, a las doctorandos Laura Miguel y Aíla del Romero, que presentan parte de los trabajos con los que optan a la obtención del grado de doctor. Ahora tengo que hacer un paréntesis para presentar al profesor Julián Cerón. Sabíamos que era investigador genetista, aficionado al fútbol, lo confirma. Es sorprendente cómo a través del fútbol puede explicar la complejidad de la enfermedad provocada por el SARS-CoV-2. Felicidades y muchísimas gracias por participar de nuevo en las jornadas de la Fundación. Y muchas gracias a la doctora Bertolotto, neurocientífica, que también un año más participa en las jornadas. No obstante, no puedo terminar este capítulo de agradecimiento sin mencionar a los comerciales Smith & Nephew, BTI, que nos dan apoyo logístico, a la biomédica Patricia Laiz y a la señora Isabel Peñarredondo, almas de esta reunión virtual. Nos vamos a estrenar como técnicos audiovisuales. No sé si alcanzaremos el grado de perfección, pero puedo asegurar que pondremos todo el esfuerzo necesario para ello. Deseo que estas presentaciones les sean útiles para ampliar conocimientos y quiero recordarles que durante el día de hoy pueden asistir virtualmente a las charlas. Si tienen dudas pueden enviarlas a través del Twitter con el hashtag que verán en pantalla y nosotros intentaremos responderlas todas. Y si quieren asistir en otro momento a alguna de las sesiones de este web seminar, podrán verlo en nuestro canal de YouTube. Esta es la parte más positiva de tener que reunirnos virtualmente por el coronavirus. Y sin más, vamos a iniciar esta jornada. Doctor Cugat.
Good morning, everybody, and good afternoon. The people are living in Asia Pacific, and good night, good morning. The people are living in North and South America and the center of America. The first speaker, as presented by Dr. Garcia, is the Professor Mark Whale, and he speaks about the precise editing of human genome for therapy. Mark, thanks for coming, and thanks for cooperate with our foundation. Thank you very much. It's your time.
Yeah. Excellent. Let's see if I can share the screen. Excellent. Wonderful. Actually, I guess that you can see my screen well, and can you hear me well? Excellent. So first of all, thanks a lot for this invitation. I'm very happy to present here. So my name is, I am an assistant professor at Pompeu Fabra University here in Barcelona. And basically my lab is focused on developing technologies for applied genetic engineering. And today I will discuss how we develop these technologies and also how we use them for medical problems. So this is the outline for today. So I'll discuss first how we can create new technologies to really insert genes in very precise places of the genome. And then I'll show how we use this technology to, for example, address a medical problem, in this case, a muscular dystrophy caused by mutations in the LAMA2 gene. And then if I have time at the end, so I'll discuss a bit of another line of research where we modify the skin microbiome to address different problems of skin disease. So I'll start with the first block, which is how we can create technologies, in this case, to do safe and efficient engineering of the human genome. So I'm sure you have heard recently, right, this big development that CRISPR was just very recently awarded by the Nobel Prize to the Jennifer Doudna and Emmanuel Charpentier for the discovery of this fascinating molecular machine. And basically, normally when we use CRISPR, we do a double-stranded break in the genome, and then we induce repair of this double-stranded break, and this is useful for therapy. However, people have brought this technology beyond that, so we can use CRISPR as a nuclease to basically disrupt genes or also to repair genes. But actually, it has even been re-engineered, this technology, so that we can replace bases in the genome. So then, in this case, the CRISPR is combined with a catalytic center that, in this case, can change, for example, Cs to Ts or Ts to Gs. Or A to G. Sorry, that's a typo. Even more recently, people has brought this beyond that. So the technology that I just presented was the base editors. You may have heard also that a new technology called prime editing has been developed. And in this case, not only we can change Cs to Ts, but also we can change almost any sequence that we want. So we can induce small indels, small insertions, or even small base substitutions. And the way that is done is by combining the protein Cas9, this molecular machine that can find a specific point in the genome, in this case with a reverse transcriptase. So then basically we can use a gRNA to guide this machinery to specific points of the genome and also to induce specific corrections of the genome. Actually, it has been fascinating how fast this, basically the very short time between discovery to applying it into patients. So CRISPR, I think, was first demonstrated in human cells in 2013. So we already have clinical data from efficacy studies. This is from January last year, or even from some early efficacy. So here we have like, sorry, I don't know what. So we have first one safety test in immuno-oncology. So basically using CRISPR to engineer T cells for cancer, or actually more recently also using CRISPR in this case to address beta thalassemia or sickle cell anemia. In this case, we even not only could get some information on the safety of the treatment, but also on the efficacy. Here you can see how the shares of the companies sponsoring this trial increased during the day of the announcement of that. Basically, 2 patients, one sickle cell disease and beta thalassemia patient, they got basically positive efficacy results. However, we have these quite good technologies to basically modify small alleles. But what happens if we need? So basically, we can use CRISPR efficiently to disrupt genes. Actually, the 2 demonstrations I showed in the clinic were disrupting genes, basically genes in T cells, like, for example, PD-1, so genes that are a break in the T cells, so to activate more the T cells, or in the case of the beta thalassemia, actually, what was disrupted using CRISPR was the gene that keeps dormant the fetal hemoglobin. So that then by destroying this negative regulator, we can recover fetal hemoglobin in these patients. Also, I showed how base editing and prime editing seem promising to modify small alleles in human cells. However, we still have a problem. What about delivering big genes? Because very often in many genetic diseases, actually it would be very hard to create a medicine for every mutation of every patient. So do we have a good CRISPR technology to transfer full genes in specific points of the genome? So this is what I will present today. So far, when we have to transfer full genes in therapy, actually mostly the technology that is most used is lentiviruses or retroviruses. For example, the approved CAR-T therapies use normally retroviruses, so lentiviruses, or for example, some of the gene therapies approved, like Strimbolis, they use retroviruses. And actually, you may have heard in the news recently that actually basically the distribution of Strimbolis, so basically the company Orchard Therapeutics, they announced that actually they detected 1 case of leukemia in one of the patients that were treated with Strimbolis. This only happened, I think, the week before the last, so very recent news. So in this case, very likely the leukemia will be caused by the retroviral vector. So we need to be very careful with that. So this is really a wake-up call that we need more technologies to do safe genetic gene editing for therapeutic purposes. And then CRISPR has also been used to try to insert genes. However, we are seeing some concerns. One of them is the relatively low efficiency of CRISPR by inserting large pieces of DNA, and also some problems with genomic vandalism. So basically, some side effects that CRISPR could cause when doing this operation. In our case, what we have tried to do is to combine an element which is highly precise, which is the Cas9 protein. But in this case, we combine this Cas9 protein with a catalytic center, so a molecular machine that is capable, that is a professional, if you will, catalytic center to do the gene transfer. So we combine a bit the best of 2 worlds: the precision of CRISPR with the capacity of gene transfer, in this case of a transposase. And this technology, we call it Unilarge. I'm going to show a bit how it works and how we created it. So in this case, we combine the insertion of a gene of interest with the selecting of a genomic target. And in this case, we could demonstrate that this technology is relatively efficient. And actually, one important feature is that it scales well with size. So we can insert small genes as well as large genes. And also, we can be quite precise. I'll show some data. And then another important feature is that we believe that this technology is quite universal from the point of view that we don't detect too much on the DNA repair machinery because the insertion is carried out by a transposase. So we can target dividing cells and non-dividing cells. This is a bit the mechanism, an illustration of the mechanism. So basically the protein Cas9 finds the place in the genome where we want to do the insertion. And then basically the transposase, when we find this place, when we mark and start the insertion, so basically the transposase inserts, in this case, the therapeutic gene into a precise position of the genome. So this is some data that we collected. In this case, is in a cell model. So we could show that by using this technology, so we can get efficiencies that are quite high. Actually, they are as high as the technologies that are not directable. So we are as efficient as, for example, a hyperactive transposase. Another interesting feature is that, as I mentioned before, we can we can be more efficient. This is compared to classical CRISPR, so CRISPR using homologue recombination. And actually, we are always more efficient with CRISPR, but actually the gap of efficiency increases dramatically with size. So actually, especially when we are inserting genes that are large, the efficiency is much, much higher. In terms of precision, one of the important features is that we want to be very precise, so really insert in only one position in the genome. And actually, this with engineering the transposase, we really manage to really increase the precision quite dramatically. Here you see the non-engineered version. You see how many red dots. Every red line indicates an insertion. And actually here the target is where the green line is. As you see, it's not precise. However, after the engineering, you see that we get this very precise, basic, almost perfect specificity, where we only get insertion here. In this case, we're targeting the alpha subunit of the TRAC locus, the TCR receptor locus. And in this case, the measurement of the insertion was done with a technology called GuideSeq, which is quite some standard technology for detecting of target insertions. We have tested this technology in vivo. In this case, we have delivered this molecular machinery using a nanoparticle into the liver of mice. And you can see that also in vivo, we can get very high efficiencies. And here you see the copy number measured by qPCR, or here you can see luciferase, basically how the delivery has worked well in the liver. We have started to use this technology for a specific medical problem. In this case, we have been focusing ourselves in the congenital muscular dystrophy type 1A. This is actually is the most frequent congenital muscular dystrophy, and is caused by mutations in the LAMA2 gene, which is a gene from the extracellular matrix of the muscle. And actually, one technical peculiarity is that this gene is very large. So current technologies, the classical AAV technologies wouldn't work because this gene has a size of 9,000 kilobases, 9,000 base pairs. So in this case, with this technology, we can be competitive to deliver this gene. We have been using a quite established mouse model, which recapitulates relatively well the disease. It's true that, so for example, it's not like the mice model for Duchenne, which is a bit more difficult. In this case, it's a quite good model of the pathology of the disease. And here we have tried different things. One is basically measuring the lifespan of LAMA2 treated mice. As you can see, the lifespan goes back to normal after the treatment. And also we could measure how these mice gain muscular strength using here a grip assay. This is very preliminary data. We have to really characterize more in depth, especially the phenotype of characterizing really the mobility of these mice and the muscular strength. And also here some more experiments. As you see, the treated LAMA2 mice actually really go back to almost normal lifespan. So in summary for this part of the talk, so I think we could demonstrate that we could generate an efficient programmable transposase, so basically a molecular machine that allows us to insert specific at the specific locations of the genome small and large genes. And that we can use synthetic biology to really enhance the safety profile of these human advanced therapies. And we have very preliminary data where we can observe some good phenotypes after treatment in the muscular dystrophy mice model. Actually, I also wanted to present very, very briefly another line of research from our laboratory. So 2/3 of our laboratory developed technologies for human genome engineering, but also 1/3 is also engineering our metagenome, especially the bacteria that live very close to our skin. You know how important is the microbiome for our health. Lots of studies have been published, and also how basically this has been a very, very important. So there is lots of connection on physiology, and also we know that these bacteria are very important molecular machines, and we could engineer them to do quite interesting things. So, and we have different ways to engineer the microbiome. One of the ways would be more from a probiotic point of view. So basically, we modify the population of these bacteria. We know that these bacteria, they can influence, for example, in our case that we are focused on a skin, they can influence important properties like the sebum production, the immune modulation of the skin, or even like the pH. So one option is just to modify the population. So this has been quite successful in other fields, like for example, in the case of the Clostridium difficile infections, actually it has been demonstrated actually quite good success of using, in this case, a fecal transplant to address this problem. So a little bit inspired on this principle. So we have developed methods to do basically these transplants on the skin. This has been done in collaboration with a company, as Biomedic. And basically, in this case, we have focused mostly in acne. Acne, there is a dysbiosis basically, this is a dysbiosis on the population of these bacteria that populate our skin. And here, what we are trying to do is basically to reestablish the population of bacteria that are associated with the more healthy states of the disease. But actually, this is very easily said. So the first question is, actually, can we engineer the microbiome at all? And this actually, I will not explain it. So this is something that we published a couple of years ago. So actually, we did some studies with a quite big number of healthy subjects to see if we can modify the skin microbiome. If we put new bacteria in the skin, do they engraft? Because of course, one would think if we go and have a shower, if we go to do sports, maybe the population will change again. And actually, we could show that actually is not the case. Especially with a very simple experiment, we work in a platform that we're mostly focused on Cutibacterium magnes, one of the bacteria that lives more in the inner parts of the skin. And actually, we prepare different formulations and we apply to human subjects. And then basically, we let these subjects go home. And basically, we sample them over time, at several points, several weeks and several months after. And actually, it was quite interesting to see that actually the populations of bacteria that we had put on the skin, actually they persist. They persist even up to 2 weeks after this initial application, which answers the question that actually, yes, we can modify the skin microbiome. Also, we have run some early studies in efficacy. One thing is that we can do the change, but do this change induce positive aspects in the skin? This is a very small clinical test, very preliminary, where we could observe some good trends in these patients. This is with acne patients. Now this study is being repeated in collaboration with the company Bayersdorf with a big number of patients, because you see here the numbers are very small, and actually there is it's not a randomized placebo-controlled trial. It was really a funding. We had some funding limitations in this moment, but now we are doing this study on the proper way. So as a conclusion in this part, so we could show that our probiotics based on C. agnes, they have excellent safety profile, tens and tens of subjects and patients treated, no issues associated. Also very important, these bacteria engraft on the skin, so if we put them, they stay there. And then we could observe even some positive trends in acne vulgaris, but of course this will need to be confirmed with a larger clinical trial. However, in our lab, we are trying to bring these technologies one step beyond. So one thing is that modifying the composition of the skin microbiome, but actually what we want to do is also to change the genes that are in this bacteria. And in this case, we're following. So actually, there have been some efforts on that direction. This company, for example, Azitra, is modifying another skin bacteria to basically to compensate, for example, in this case, for a genetic disease. Also, some other companies and researchers have created probiotics, for example, to express cytokines, for example, to accelerate wound healing. So it's something that is being done with a relative success. So, and this is our cycle. So on one hand, we know that we can modify the skin microbiome. We can add, for example, probiotics, and they stay there with C. acnes. During these last 2 years, we have been developing methods to modify these bacteria so that then we can add new genes, add new functionalities. And what we are doing right now with these tools is first to teach this bacteria to listen, for example, to create sensors for this bacteria that basically they could basically sense the sebum production. They could sense whether our skin, the immune state of our skin, even some environmental factors, and then other genetic circuits that they could actuate, for example, depending on this stimulus, they could, for example, induce immunomodulation, induce basically sebum modulation or other properties. And with that, I just wanted to finish. I would like to thank my lab. Also, thanks to the organizers and to the foundation for this invitation. It was a pleasure, to participate. And I am happy to take questions.
Professor Marway, for this wonderful talk. I think it's not so easy for orthopedic surgeons to understand very well all this technology, but I think it's the future. Okay, and we have some questions. Then we ask to you because the hashtag is open, and for the moment we don't have questions. But I'd like to ask to you. You talk about CRISPR, and CRISPR, I suppose, needs to be very precise. And you present two different kinds, with by an engineer and with the cast, no? I think, and it's different because it's more exactly one to the other.
Yeah, definitely. I think that's a very good point. Actually, it's a very important point because actually one of the problems with the classical CRISPR, so the classical CRISPR would be like just the protein that does it almost basically cuts, right? The molecular scissors. Actually, we have observed that using CRISPR in that way, it could create some problems, what we call genomic vandalism, because sometimes it does the modifications that we want, but also others that could be dangerous for the patient. So that's one thing. But people have done different, let's say, advanced phases on developing further on this CRISPR. And I think then, for example, these two new generations, the base editors and the prime editors, then it's a bit different. It's much more controlled, the system, because it's not a molecular scissors anymore. Then it's directly something that changes the sequence on a more defined way. The base editors, it changes one base to the other, so very defined change. And in the case of prime editors, actually you can replace even words. They call it search and replace, a little bit analogous with the Word, right? The Microsoft Word. Which in this case is much more controllable. In our case, we are trying to do something on that direction. So in our case, we are trying to use CRISPR only to find the position in the genome, but in our case, the writing, the insertion is done by a transposase. So again, trying it to make more precise. So more precise, which means more safe for the patient.
Perfect. And when do you think that will be applied in the human?
In the human, these last versions, actually, I just heard that, for example, the base editors, I just heard last week that there was an IND registration in the US by the company Beam Therapeutics. So very likely we'll see a clinical trial soon, probably the next month for base editor. For example, in our technology, we are a bit still probably some time because we have done experiments in animals. So first we need to do GMP production of the reagent. So probably we are talking about like still maybe at least many months, probably we need a year or two before completing this process.
Perfect. I think it's a wonderful talk. I like it very, very much. I am orthopedic surgeon, but I am very, very interested in all the genetic, all the biology, because I think it's the possibility to advance in our treatment of the patients, because the orthopedics, I think we need to know more or to have an interrelation with the biologists, scientifics, science people are working in the gene therapy, because I think that is the future. We need to move, because if no, the technology in orthopedics is very old. Just the new models, the new prostheses, the new cements, the new. And I think we need to change the idea, because not try to resolve the problem when the problem has been instaured in the patient previously, to prevent. I think that is I like it very, very, very much. And I agree very much, Professor Maruel, because has been wonderful, wonderful, wonderful talk. Thank you very much, and we'll be in contact. Thank you.
Thank you very much. It was a pleasure to participate.
Thank you. Thank you very much, Mark. Thanks. And now we'll continue with Professor Mitsuo Ochi. Mitsuo is a professor of orthopedic and sports trauma of the Hiroshima Prefecture, and nowadays is the president of the Hiroshima University. He's a big name and has writing a lot of papers, books, and has a big group of research in the University of Hiroshima. And the paper has been pre-recorded, okay? And can we see, please? No, now. Thanks. Thank you. Here we have Professor Mitsuo Ochi.
Diu que facis la teva presentació i ella ho arregla. Digues, haces un comentari.
Ponemos la cámara.
Yeah. I'm sorry, but we need to change because it's not ready, the presentation of Mitsuo. He sent to us, but the problem is our problem, okay? Not for him, okay? And now we'll change my talk. It's just about the cartilage, okay? The basic principles of the condyle defects and how we treat nowadays here in Barcelona. Okay, that is the title of the basic principles in condyle defects and treatment. And here is all the people are working with us as a multidisciplinary group from veterinary medicines, etc., etc. You can see, okay, in Barcelona. That is my disclosure. And perhaps we need to start to speak of cartilage. Cartilage as the histology and biology, because the cartilage has the extracellular matrix everybody knows, and then is the chondrocyte. And normally the growth factors works similar an orchestra. The growth factors activate chondrogenesis, not only a single growth factors. We need all the group, all the orchestra. And the growth factors work synergically to enhance cartilage matrix synthesis through BMP7 and insulin growth factors. And the insulin growth factors and fibrotic growth factors and TGF-beta regulate their own and each other's gene expression. Normally, when we work on biology, need to work the scaffold, cells, and the signaling molecules. And now we'll go to talk about growth factors as signaling molecules that regulate a variety of cellular functions, such as cell growth, proliferation, migration, and differentiation. And the key factors of PRGF and DORET. Why PRGF and DORET? Because we don't use leukocytes, we don't use red cells, and we activate it with calcium chloride, and we increase 2.5 times the number of the baseline platelets. That is the reason we use the name and surname is a PRGF from Endoret. And as you can see, we have 5 types of formulas. Non-activated, activated, when it's gel, when it's fibrin, and supernatant. That is the 5 formulations we have when we use this PRGF. The injections. Normally in the condyle injuries, you can see intra-articular injections is outpatients, not surgery, augmentation, and just we inject inside the knee joint. And you can see how is the study and the optical microscopy, and then this vision is the injury and 7 months post treatment. This by arthroscopy and the second look. The other kind is the subchondral bone injuries and intrabone, and in the surgery room and the fluoroscopy control, maybe in the ankle, in the hip, in the knee, in the talus, and you can see here in open surgery of the patella injury and patella facetectomy. We need to do it. And we use scaffolds and cells. As a scaffold, we use 3-dimensional matrix, and that is autologous scaffold is coming from ERP. And then we mix cells, that is not stems, is autologous. And we have better results, but it's perhaps more complex because we need to go always in the surgery room. And that is useful for the condyle defects, not for osteoarthritis. And why? What happened in the autologous liquid as to the gel in dynamic scaffold as carrier of biological mediator in tissue repair? Here we can see there are two ways. One is degranulation, la batería está agotando. When degranulation of the platelets, some growth factors goes directly to receptor of the membrane and works inside the cells. And the other, when is trapped in the membrane and then is delivery from the mesh and then the actuation at the same receptor of membrane, and then create a modulation of biosynthesis of these growth factors. Here we present a pilot study in a sheep model, because the idea was it's possible to regenerate the cartilage. And we can see here the first is after sacrifice the animal at 1 month, the second is at 3 months, and the third is at 6 months. And we can see chondrogenesis and regenerate cartilage with collagen type 2 at 6 months, with nearly normal microscopic ICRS assessment. Optical and electronic microscopy, equivalent structure to mature cartilage. And this treatment is easy, is effective, safe, reproducible, and cheap alternative option to treat chondral injuries. That is the soccer player. Has a contusion, and you can see the condyle 4 degrees, and he lost all the cartilage. And from July 2015 till now, we operated 159, the majority is soccer player. And we perform this clot with the growth factors mesh plus the minced pieces of cartilage. And then we cover with the supernatant the growth factors, some drops, because, and we don't use another mesh. Why? Because in the growth factors, there are several proteins has the potential of adherent, and we can stick it in the area on the interdefect of the cartilage in this femoral condyle. And here we can see another in the trochlea, and here is not acute. This fracture was a chronic. That is the reason we create a small microfractures, very thin, and then we apply. You can see the technique when it's mixed, the minced pieces of cartilage and the mesh of growth factors. We use a 50% of the fraction 1 and fraction 2. Fraction 1 is poor, and fraction 2 is rich in growth factors. We can apply not in arthroscopy with the serum. For this case, it's much better to do an arthrotomy, and this way we cannot lose some growth factors. It's possible to apply not only in the condyle, not only in the trochlea. You can see here in the patella, in the condyles, see another in the trochlea, and we can use in osteochondritis, osteochondral lesions in the talus. That is so common in the soccer players. And we can see here in the flexion extension and the mesh is skipping. The idea is to cut all the borders perpendicularly, and in this way, in the movement, it's not possible to lose the mesh. Sometimes we can do, for example, the same time, the meniscal transplantation, the anterior cruciate ligament, and the mesh of the condyle in the same soccer player. Here, this study was performed by Dr. Alentor, and the evaluation, minimum 10-month follow-up. And you can see the excellent is over 70, 15 case, not regular, no poor. But in the mocker with imaging, you can see 9, 4, and 1. There's the second look. First, just the fracture with liquid injection. And the other is with the PRP matrix plus cartilage chips. You can see the difference. It's quite similar. It's very difficult to see the difference, the normal and the abnormal from the mesh. And the summary, nowadays, it's most common to use 2 steps. Isolate cells culture in the lab, expanded, and then in the second step, surgery, implantation. And we put some mesh. Our treatment, our idea is to use only 1 step. Remove the piece of cartilage, cut it, minced pieces, mix with the mesh of growth factors, and then apply. The conclusions: intra-articular PRP, decreased knee pain, increased function, but poor results in Genovaro. Genovaro knees is not necessary, use it because it's a mechanical problem. And intra-bone PRP stimulates subchondral bone, rich deep layers of cartilage, and is useful in osteoarthritis, necrosis, and osteochondral lesions. 3-dimensional matrix, always 1-step surgery, improvement in function, pain decrease or disappear quickly, and the images show improvement. Not only stem cells have regeneration potential, non-stem cells, signaling molecules, scaffolds can promote regeneration also. And don't forget, not only we have spoke about the scaffold, the cells, and signaling molecules, but we need to think they are 3D, bioprinting, other cells as Muse cells, other blood-based therapies, gene therapy, as demonstrated previously the Professor Marway in this excellent paper. And thank you very much for your attention. Thank you. Questions? No. And now I suppose, I'm sorry, we'll go back, if it's possible, to listen and to see the presentation of the Professor Mitsuo Ochi, because he is president nowadays of the Hiroshima University. Thank you. I'm sorry, because we cannot listen the Professor Mitsuochi, he explained, but I'm sorry. We need to try to obtain the listen, because if no, it's not possible. Bye.
Hi, good morning, everybody.
Oh, yes. Thank you.
If you are in European time zone, it's already evening in Japan. It is my great pleasure and honor to talk about articular cartilage defect using mesenchymal stem cells during this online meeting organized by Garcia Cugat Foundation. First,
Ya no va. S'ha parat. Qué desastre, Dios mío.
Ramon Cugat and more than 20 very close friends.
Madre mía.
About myself. Now, 5 years ago, orthopedic department at Hiroshima University. Hi, good morning, everybody, to talk about articular cartilage defect using mesenchymal stem cells during this online meeting organized by Garcia Cugat Foundation. First of all, I would like to express my sincere appreciation to Dr. Ramon Cugat and Dr. Monse Cugat for this opportunity. I got acquainted with Dr. Ramon Cugat and Monse Cugat more than 20 years ago. Since then, we have been very close friends. These photos were taken in 2011 in Barcelona. This is COI closure. Now, allow me to tell you a bit about myself. As I mentioned, I'm president of Hiroshima University. Now, 5 years ago, I was a professor and the chairman of orthopedic department at Hiroshima University. Hiroshima University is located in Hiroshima Prefecture. And the Hiroshima Prefecture is in the southwest of main island in Japan. Hiroshima Prefecture has 2 World Heritage Sites. One is Itsukushima Shrine, as you can see on this slide, and the other is Hiroshima Peace Memorial Park. If I may, I would like to share the following slide with you. I personally think there are several great achievements disseminated in the world in the 20th century. As you can see, total joint replacement has been established in Europe and the United States. However, arthroscopy and microsurgery techniques have been actually developed in Japan. It was Professor Tamai who successfully performed the first case of the replantation of thumb in the world. Professor Masaki Watanabe was a pioneer in developing modern arthroscope and techniques. This video clip is the first case of meniscectomy under arthroscopy performed in 1962 without TV monitor. This patient was the basketball player. Meniscectomy and arthroscopy was successfully performed. Now let's get started. This is what I'm going to talk about today. As you may agree, the bone marrow stimulating technique and arthroscopy may be a surgical option as a less invasive procedure. By drilling bone marrow, MSCs are induced to the cartilage defect area. Although drilling, ablation, and microfracture can be done easily under arthroscopy and induce mesenchymal stem cells into cartilage defects, newly formed tissue is not hyaline cartilage, but fibrocartilage, and it degenerates over time. Bone marrow mesenchymal stem cell can differentiate into chondrocytes and stimulate cartilage regeneration. However, regenerated cartilage degenerates. Hence, the clinical results are not always satisfactory. There may be various reasons why the bone marrow stimulating procedure does not induce satisfactory results. One of the possible reasons may be that insufficient number of bone marrow mesenchymal stem cells are available by drilling in the knee joint. Our new trial was intra-articular injection of cultured autogenous MSCs after drilling under arthroscopic control to augment the number of MSCs available for chondrogenesis. The background of this study was that Peterson et al. Demonstrated that bone marrow mesenchymal stem cells automatically move to the injured liver after intravenous injection. We performed intra-articular injection of MSCs with green fluorescent protein, GFP, to repair articular defect in an animal model. This slide shows the histological findings of the cartilage growth 12 weeks after drilling. After drilling, the cultured bone marrow MSCs are injection. On the right, as you can see, the injection of cultured bone marrow MSCs promotes cartilaginous healing after subchondral bone drilling. However, intra-articular injection of excessive number of MSCs resulted in the formation of scar tissue in the joint. Magnetic therapy. One of the problems with the intra-articular injection of MSCs to the knee joint is that they may scatter around there after injection. To solve this problem, you need to be able to come up with cell-targeting procedure to actively deliver the injected cell to the defect. As you may know, CD133 or 34 cells can be selected using magnet and magnetic beads. We conceived a new procedure of accumulating a relatively small number of MSCs to a desired area using magnetic force with the aim of avoiding side effects such as the production of free body and scar tissue. The procedure we have come up with is a magnetic procedure using magnetic beads. These magnetic beads are nano-sized particles and already in use for human MRI as imaging agent. As you can see, a metal clip is attached to a plastic box with powerful magnetic force, which is placed 15 centimeters away from the surface of the magnet. Under this condition, the complexes are injected in the knee joint and the MSC complexes are attached to the region under the magnetic force. Before making a clinical application, we are requested by the authorities in Japan to precisely examine the safety test of MSC after being exposed to magnetic force. The test entailed conducting karyotype analysis, colony formation, and cell proliferation tests et al., which are intended for checking the malignant mutation of the cells. This slide shows the result of cell proliferation test. No abnormal proliferation of MSC was observed. In the bottom right, most of iron particles were released from MSCs after 2 weeks in culture. The clinical trial was approved by Ministry of Health, Labor and Welfare in 2014. It's a long journey from the start of animal experiment to the approval. Altogether, it has taken 13 years. This shows temporal change of MRI findings after application of MMSCs. The defect has been repaired with hyaline-like cartilage. According to IKDC score, the clinical scores were significantly improved up to 48 weeks after surgery. The point of this study is that it is not a controlled study because the main focus of this study was to investigate the safety after the treatment. This slide shows the arthroscopic views of the 3 patients who have given their consent to second-look arthroscopy. This magnetic therapy has been taken up by Al Jazeera English medical program, which is a current affairs satellite TV channel.
Which can lead to chronic pain and disability. That's because cartilage, unlike other tissues, doesn't have its own blood supply, and so heals very slowly. I'm Dr. Javed in Hiroshima, Japan, to meet the surgeon pioneering new techniques in regenerating our knees.
I have another new procedure using magnet.
The goal was to devise a less invasive procedure, much like the original idea of simply injecting the cartilage.
If we inject so many cells, 10 million cells, we observe scar tissue in the knee joint because you see the injected cell become scattered.
So if you inject cells blindly into the fluid capsule, they go all over, and that made scarring. So you'd rather it just goes to where there is actual injury.
Pointedly.
Right. pin it in. So how did you achieve that?
So I decided to use small iron particle.
How did you do that?
Mesenchymal stem cell
Yeah.
can phagocyte small iron particles.
So the stem cells eat the iron particles.
Yes. Then they can be controlled the direction with a strong magnet.
Oh my lord, that's amazing.
And with magnetic force from here,
Oof, there's the injection.
cells are attached to the defect
Yes, they
area.
are. It's being channeled that way.
Yeah,
You
yeah.
can see it very clearly. By some sort of trick of nature, these
Several types of magnet for clinical use. On the top, there is a superconducting magnet of 5 Tesla, which is very expensive. In the bottom is a neodymium magnet. Compared with the other magnet, it is less magnetic power, but it is still very effective and requires no electricity. This video shows a new magnet for clinical use, demonstrating the effectiveness of the magnetic coil. As you can see, the red water containing iron powder is being attached toward the magnet. During the actual surgery, the patient knee is inserted at the center of magnetic coil so that the surface of cartilage defect is positioned against the direction to magnetic force. The usefulness of our magnetic targeting has been demonstrated not only in cartilage repair but also in the reconstruction process of bone, muscle, spinal cord, and urinary bladder. More than 20 English papers have been published by our department at the Hiroshima University. Next is application of magnetic therapy for typical osteoarthritis. Total knee joint replacement is a very good surgical procedure for typical OA of the knee joints. Even then, biological reconstruction using cells and tissue is also desired. So the next question to ask was this: is our procedure applicable for OA? Human OA cartilage was attached to the lateral wall of the flask, including 20 cc 10% fetal bovine serum, DMEM, and MMSCs. The bottles were spaced near the magnet, and then the specimens were divided into 2 groups. One bottle was exposed to magnetic field for 6 hours, while the other group received no magnetic exposure. This is a control group. Only degenerated human OA surface is visible. In contrast, in the group exposed to magnet, magnetically labeled MSCs were delivered and attached to the degenerated human cartilage surface with external magnetic force, resulting in a new cartilage layer well integrated with human OA surface. This technique may open a door for treating OA. Another issue here is whether it is acceptable to directly put the pressure onto the lesion when tissue is transplanted to a large chondral defect area or when tissue regeneration starts after drilling. Such a large load may deteriorate regeneration process. In the case of small defects, the surrounding normal cartilage will support them, but it is uncertain whether this will be the case with large defects. It was in this context that the method of distraction arthroplasty was developed to allow joint movement while keeping the repaired area from being subjected to large load. I have developed this distraction device for human use by collaborating with a company called Mela. After distraction, you can see the opening of lateral joint space shown by the green arrow. 1 month after surgery, this patient could flex her knee up to 100 degrees. At that time, she could walk without crutches. This is a case of a 40-year-old female patient who had a lateral meniscectomy on her right knee 25 years ago. This slide shows the exposed subcondylar bone at surgery. Microfracture was performed to promote condylar regeneration, and then disruption arthroplasty was also done. This video clip gives you some good idea how the healing is going on 3 months after surgery. These images show a good healing of joint cartilage in the femur and the tibia. On standing view, we can see opened lateral compartment. Red arrows show regenerated cartilage. This is a follow-up case of a 45-year-old male patient. As you can see, 10 years after the disruption arthroplasty, good joint space is observed. Even after 10 years, the joint space of the patient is still maintained. For the treatment of a large defect, such kind disruption is considered to be important for achieving good repair of the cartilage. My colleagues and I have reported this clinical experience in the two journals shown in this slide. To sum up, magnetic therapy alone or associated with disruption arthroplasty has the potential for changing the treatment strategy for articular cartilage damage, including OA, in the future. These are my colleagues at the Shimane Medical University and Hiroshima University. I really appreciate their warm and kind support and hard work. My friend and colleagues, please stay safe and healthy. Thank you very much for your time.
Okay, thanks for this explanation by Professor Mitsuochi, but I'm sorry because we cannot receive clear pictures. But have you seen his wonderful group? And there are a lot of people working on research, and he's a pioneer in Japan to use this kind of technique, stem cells, and applying these magnetic beams to send directly the cells as he demonstrated us. And thank you very much, Mitsuo, for this kind, very, very good presentation. Wonderful. Thank you very much. And now we have received a small some questions, but only for me, because the other is not possible. Only if you need to send, you can send, and then we try to do the answer. One is for me is in which grade of condyle injury is this biomatrix useful? Normally we're using when there is a 4-degree injury, and when there is acute is much better than chronic fractures. Normally is much better when it's acute fractures, and we cut the borders and create the hole and then fill it with this bio matrix, because it's the growth factors, and then we use the minced pieces of cartilage all together. I think it's a very, very, very good results. And then I'll go to see another. The next one is is the best, is the better, PRP, stem cell, or other therapies? In this moment, it's very difficult to say what is the best, but our experience is more in PRP and less in stem cells. But I think you have the opportunity to see Professor Mitsubishi with the stem cell and distraction on the knee. It seems in osteoarthritis has a very, very good results. And for us, PRP is good inside the knee joint and intrabone, because we can treat both sides. Because inside the joint, when there is an osteoarthritis, the osteoarthritis, the problem, I think it's mechanical one, and the other chemical. There are two big problems. And the crosstalk between the subchondral bone and the cartilage is altered. And the idea is to use the growth factors. We can help, it seems, hypothetically, we can heal this stem cells and then create less quantity of inflammatory cytokines we have in the subchondral bone. And the same happen inside the knee joint, in the synovial fluid. When we have some trauma, normally we have increased the pro-inflammatory cytokines. And I think the growth factors, in our experience, is not so expensive, and is very active, reduce the pain, and we can get better function. And the other is in the elite athletes, could return to sport at a high, same level after joint replacement. Normally, in the joint replacement, I think it's very difficult. The athletes, I never seen one is possible to go back to play at the same level in football. For me, I think we need to try to help with the biology, any kind of biology we are discussing today in this meeting. But the total knee replacement, I know I never seen play football. If you have some other question, we can send, and we can answer maybe later, or not today. Okay. Yeah. Okay, now we have 39 minutes for the coffee break, and we wait. Thank you. Danke. Què vols dir? Hagamos un coffee break, ¿no?
Tenemos una pausa para poder hacer un café y recordar que a las 12 seguimos. Hasta ahora. Y otra cosa, si tenéis, recordar el hashtag y enviarlas por Twitter. Las esperamos y os contestaremos.
Uy.